bricks on the screen, healthcare in between. Physics, art, and math got us down this path. Historical tales come alive, where science and stories dive. Blended facts with heart, knowledge from the start. Need bridge blues we sing to the future memory. Health and science in the mix. Midbridge got the fix. Complex subjects made clear. Every episode cheer. Ramona leads the way, explaining day by day. In the world of digital streams, turning knowledge into dreams. Through the tales of old, new stories unfold.
MedBix Webcast is a new kind of healthcare media channel to break the silo mentality and foster interdisciplinary thinking. Our mission is to fill that gap and to create a curiosity through different lenses, tapping the passion that guided the historical figures in medicine and bringing present-day groundbreaking research to the front lines. We interview physicians and leaders in the industry about present-day healthcare challenges on our live programming. Hello. This is the MedBix Webcast. Welcome to the MedBix Webcast. This is Ramana Namaraju. I'm the host. I am by the way, you see my different settings now. I'm traveling now. I'm in West East Coast a little bit. So it's going to be a little bit different, So I'm doing from the hotel. So the background is a little bit different. But anyway, that I have a really this podcast, I wanted to bring different kind of a thinking process for my podcast, and all kind of, my tagline for my webcast is diversity in thinking. Diversity not only in the racial or any other way, but it's also important is a thinking. Diversity in thinking allowed. Only thing is if you bring the different people in the healthcare system and listen to their voices. That's what my purpose of this MedBix Webcast. So I'm going to bring up, it's a very important guest from my hometown, back home, Hyderabad. So she's a nurse. She's a nursing administrator and a doctorate degree in nursing from Stanford Healthcare. Tell us. So a highly qualified woman. And then she's also founder of Indian Nurses Association of Bay Area. Okay. So there's a lot to talk about with her. Let me bring her to the table, and we'll talk with you a little bit more. And give me 1 second. Okay. Hello, how are you? This is a welcome to the MedBix Webcast, Dr. Arastu, right?
Yes, you can call me Fatima. Thank you so much, Mr. Ramana, for having me over here. I really appreciate you amplifying our voices of nurses here on your show. So I'm really excited to be here with you for this interview.
I said that you're from my hometown. Give us a little bit background. What is your journey consisted of from my hometown to all the way to Palo Alto and all those places?
Yeah, absolutely. It's such a blessing. I am from Hyderabad, which is really a city known for its culture, heritage, for food. If people who are watching would want to know, it's a city located in Andhra Pradesh, which is, I usually say, south part of India. Really good, known for its food, but also the climate is really amazing there. And I grew up there, Mr. Ramana, and I came here in my 20s, and I was really trying to explore where I needed to be in my career. I had a bachelor's in nutrition, and I came here under different circumstances, and I joined my mom and united with my stepdad to just kind of explore educational opportunities. And at that time, I was looking at nursing only because, my grandma got sick with dementia, and coming from immigrant household and coming here, separated from my siblings. Really, my mom needed the support, with healthcare, not having enough resources, just caring for my grandma. And it just struck a chord for me. It's like, oh, I can do more. And there was something within my heart where it felt like I can touch people and support them and make a difference in their life, because they are in their most vulnerable moment. And having that patience, that caring heart, is really important. And that was my story of like why I went into nursing. And I've done different roles within my career. I've started out really ground, started as a research assistant. Prior to that, being a clerk at a doctor's office, did a certified nursing assistant course, and made my way up in leadership. I've been in leadership for last almost 14 years. Currently, I am right now in Office of Research, Patient Care Services at Stanford Healthcare, but I also teach grad student at Cal State East Bay recently, and I'm teaching them human resources and leadership at this point. Also, I work for Kaiser as a house supervisor, so I can have my operations and still be connected to the hospital staff members. So two different kinds of roles, and I'm really excited for this journey because I don't think so I would have it in any other way. Nursing is the backbone of healthcare, and I feel like I've made a mark in that. In terms of my education background, as I said, I had bachelor's in nutrition. I also have my bachelor's in nursing from San Francisco State. And then I got a dual master's from Holy Name University. This is in Oakland. I got my MBA. A lot of time, when nurse leaders become managers, they're chosen, because that's how I was chosen by one of my leaders in San Francisco, who said, "Oh, you will be a great leader." And I'm like, that was not something on my career agenda, but sure, I wanted to just take care of people. And
And so, Fatima, can you explain what the nursing managers or administrators do? I
oh
mean,
yeah.
we all think they schedule other nurses. That's all we think. Tell us a little bit of their duties, a little bit more what they do exactly.
Yeah, no, absolutely. I think that's a great question you asked. What is the role of a nurse leader? I see, after doing this for, as I said, for so many years and more than a decade, somebody who is a coach who is looking at really the quality outcomes for the patient, but also creating that work environment so they can thrive. As you know, COVID really highlighted how difficult our environment has been, and the system is so broken. And the role of the nurse manager is not just scheduling nurses, but really, supporting the patient that's coming in to the hospital in the care of the physician and the healthcare providers. And I just don't want to leave other allied health professionals, that physical therapy, occupational therapists, nutritionists. There's so many people that who come in hand in the care of that one single patient and a family member, right? So it's a multidisciplinary care, and that is a role. It's a business, because I say that it's a business because when I am in charge of one department, that's what I have been. It has multiple specialties, or is just focused on one specialty. And you focus on that practice, you focus on research, you focus on clinical outcomes for the patient. You also look at the budget for the department when you talk about schedule, but the supply. So when I say it's running a business, because if I had to give an analogy, if I were to have my own restaurant, I need to make sure the customers are satisfied. So I will equate that to my patients and their family members. But then the team who's working together to make sure that they deliver that food. For us, it's the care that we are delivering, right? Working with our physician partners, our advanced practice providers, our physician assistants, our nursing assistants. So it's an era of people that you work
Yeah.
with. So in a nutshell, that's how I see. I looking at the policies, procedure, the best practices, education, initiatives within the organization. So, and then creating that work environment for them.
Yeah,
So,
yeah, that's definitely the great analogy that I gave because I was listening. Venki Ramakrishnan is a Nobel Prize winner for the ribosome molecule. What he said was the cellular structure, the cell, the function of a cell is like working like a major city, like in New York City or London. The way it works, all the things has to be in place. So many things go on in the cellular mechanisms. That's what he was saying. Is very impressive. I wanted to ask you. So you do the all these choreography of the all the services that you direct, and once the doctor orders all those things, and you have to somebody has to implement it. You will be overseeing that implementation of all the services provided to the patient. So you are very close to the patient's needs, and patient outcomes is a very closely tied with you with the nurses. Do you agree with that?
Yeah, no, absolutely. That's part of the organization operational goal, the department unit goal. These are something that, the value based care here in the United States, which is really focused on certain measures through, with the people want to come here because they want to see how the care is delivered, and we are compared between different organizations. So whatever organization you work for, so the role of a manager encompasses so many things. And whether it's the quality outcomes you're looking at, patient experience you're looking at, safety, patient safety pillar, staff safety, psychological safety, environment that they're working in, their competency education in terms of able to do that and deliver that care safely. So there are a lot of pieces that it gets involved in caring for these patients in the role of a nurse administrator.
Fatima, I lived in Nashville, Tennessee for a brief period of time. So there was a case. The nurse she made an error, that she gave a wrong medication to the patient. Patient died. That was a big case, and they went on a prosecution, went on a big revenge case kind of things. They lost prosecution. She lost the license, but they didn't put her any criminal case on here. But it's a sad case. The system is pressure. What she said was, I did not do. The system is whatever the things available. It's so much pressure we have to do, and the system is a flawed in that they want to dump on the nurses. So tell me, the burnout that system creates, that the whole system falls on you in nursing area. That is a lot of pressure it creates, right, for nurses.
Yeah, I think the model that we have, and I think I'm glad you brought that, because we want to function in a just culture environment to look at what are the root causes of in a situation like that. And it was really unfortunate that the nurse had to experience that in her career, because you come into not harm anybody, right? Because you come into this profession, and every person, every day when they go to work, they want to do their best, be the best version of themselves, provide the best care. And burnout is real for physician, nurses, allied healthcare professionals. It's just because the system the way it is. And for nursing, I can say right now there is a movement on, there is a commission that's been set up of re-looking at how nursing is seen in the budget within the organizations, because we the way nurses are carried out on a hospital healthcare bill in layman words is, it's not charged per the nursing, it's by the care hours. But it's not like, if I assign one nurse or two nurse versus physicians, it's a little bit different. So it's built um, together for the nurses. So we really want to look at how nursing is valued within the budgetary options of, repayment or reimbursement process. I think that's a big part that we need to look at. But the other aspect of burnout is, people are going to retire. There are almost 10 million nurses who are going to retire in 2030, and we need to replace that. But then there's this, it's a vicious cycle. There's a backlog, because although we do want to bring in more nurses, but people are also leaving the profession because of the burnout. And the burnout is not only is just in the frontline team members or the clinicians, I should say, not even frontline, but really the nurses are the clinicians who are there with the physicians and other allied health members. The burnout is really strong, but we haven't created the pipeline because the system is broken, as I said. Not only healthcare, but even our teachers, right? There is a shortage of nursing teachers. There are a lot of programs that are closing, or if because they don't have enough clinical placements. There was just a recent bill through Association of California Leaders that is, really asking for nurse leaders to really weigh in, where out of state students will be allowed to come in and do their clinicals and compete uh, with the nursing students here in California. That's going to really create supply and demand issue. So there are a lot of other, intricacies around it, and that's what we are struggling with right now at this point.
Fatima, just forgot to ask you that. It's important. How did you manage the during COVID times? People we didn't at that time. We don't know what it is. How did you? You're on the front lines and you're seeing patients every day. How did you manage that? And how? What are the mental state of the nurses during that time?
I think it was really hard. I do want to say there was, I'm grateful for the organization that I work for. I was an inpatient manager at that time. I had four different service lines, which is when I say within my department, I was specializing in post surgical patients that were in orthopedic, cardiothoracic, uh, plastic, bariatric, and then any other general surgery patients. But when COVID hit, it was really hard because you didn't know, right? We didn't had answers, and it's okay to not have answers, but we were in a situation where, you know, people felt very uncomfortable with what they were dealing with because it was something different. We were not prepared for it in a way where we needed to, more psychologically. But I was really grateful for the organization that I worked for because we had the support of our leadership team. Staffing was still tight, to replace team members for the care. It was difficult at times, and then we had to come up with new processes every now and then. The burnout around that, you know every day there's a new process on how to, we call dawn and dove. That means when we are going into a patient's room, the masking and wearing a surgical mask or not, a respirator mask. What kind of mask are we using? The fitting of it, and then people getting exposed, making sure that everybody, the communication is on the top for that. People are being heard. And I don't know if you recall, Mr. Ramana, it's also the time during COVID, George Floyd incident happened. So there was a lot of disconnect, distrust in leadership, belonging, and it was within the, not just for hospital organizations that they were dealing what was happening in the outside, but for the first time, I think we realized what happens outside of our work impacts our mental state within the work environment, and I think that was very, very prominent. And for me was to really be there for my team and be as authentic and transparent as I can be of what the situation was, and to be able to know that I might not have answers for them for things, and work together to be more resourceful and collaborative and be honest and true to my values. And a lot of people came through and supported, and I'm grateful because the team that I work for, I hands down amazing team that I work with. So I was very grateful for that.
Fatima, the Silicon Valley is a lot of Indians and Chinese, a lot of Asians there. So you're from a diversity, equity, inclusion point of view. You have nurses. Not, I saw some nurses, but most of the nurses are that diversity. We're talking about on your website about the diversity part of it, inclusion, equity. So tell us a little bit, because the patients, they sometimes related to their cultures, their backgrounds. So this is a big important thing. A lot of times their studies are done, so they can relate to, you're from Hyderabad, people from Hyderabad, I can relate to you immediately
Yes.
fast enough. So that kind of a connection that you can get. So what do you think of the diversity in the nursing industry? I know the physicians are quite a bit. What is going on in the nursing industry, nursing side, for the diversity and equity and inclusion aspect of it?
And this is a great question because I think we're now, like, I know a lot of people would say there's no such thing as melting pot within United States, but things are changing, right? We are mixed race, right? We
Yeah.
are a mixed race now. But how do we represent the community we serve? And that's why the community health assessment, every organization does that. every organization within their county or wherever they are positioned, they do their community health assessments to understand the people they serve within their area, to understand how do they resemble, and then that composition is really important to ensure that your staff is diverse too, and you have that, or not only if they are diverse, but they have that competency, their training, and their diversity. I think you said it really well in your caption: diversity in thinking, right? And how do you show up that way, and how do you become that kind of organization? I'm grateful that I've been working for organizations like that. That has been really incredible opportunity. But for nursing, racism in nursing commission came through American Nurses Association. They had just done a commission report on what racism in nursing look like. And when that report came out, a lot of people didn't want to talk about it, because a lot of nurse leaders thought that it doesn't exist in nursing, because our job is to care for everybody. We never do that, but it does exist. So that report was very eye opening, because it took us back in time and history, how healthcare was and how nursing was. For African American community, that in healthcare, there was a divide, right? There was a hierarchy. Same thing in nursing. Not a lot of people know who are the leaders who have contributed based on ethnic backgrounds. Like, this is a Hispanic Heritage Month. Not a lot of people understand that, how that impacts in the care we deliver and the outcomes, because you can, as you said, you and I are from Hyderabad, so there is a connection.
Mhm.
Not that we know it, but we understand. Okay, yeah, you're from my hometown, you understand certain things, I can understand, I can relate, a sense of belonging. And when we serve our patients within our communities, we need to represent that, and then have that understanding and open mindset about that, where we are, what times we are. And this is a big thing for me. You know, we are capped into American Asian, and Asia is such a big word. When I say Asia, you're thinking of all the countries. If you were to ask me, Fatima, tell me how many Indian nurses represent within the California and give me the number, I'm sorry, I wouldn't have that.
Mhm.
We California Board of Registered Nurses have, for California, we have almost 540,000 nurses. Out of that, I don't have a number of how much of we represent. I know within United States, Asian American nurses are represented 6% of that population, and we have 5 million nurses approximately for United States. So, given that ratio, it doesn't really
Yeah.
meet the patient population.
So that's one of the things. He started a, organization. I will come back and ask you. I'm going to present a small topic on it, and one of the ladies from a very forward-thinking woman. I'm going to present a topic about her, and after that, I come back and I will ask you about your founding association, Bay Area Indian Association. You started it. You're definitely a leader. I think very impressive. You were talking. You're really a true leader in my view. I think you articulated all the things that what nurses go through. So I love to listen to you. And let me present this topic and come back and talk with you a little bit. But you and me are going to watch together, and you can jump in anytime you want to. Okay. So this is the topic I'm going to do. Is a 15-20 minutes. I'm going to do about this. Just let me give me some minute. 1 minute. I will put you on the side, both of us. Yeah. Okay. This is the that is a Dr. Fatima Arastu. She's a PhD in nursing, doctorate in nursing practice, and she's MBA. Oh God, overqualified for anything she does. I think she's a tremendous. That I'm glad to have her on my podcast. Let me go into the different woman from local area. That is a woman from a professor of. She changed a very different aspect. She was talking about the statistics of Fatima, about 5 million nurses here. She came up with the idea as to how many, if the world is of only 1,000 people, what would be the case? So what she did was she came up with a statistical study. There's a five soldiers, seven teachers, and one doctor, and three refugees. That's the distribution among 1,000. Rest of them are men and women. That's the distribution if there is 1,000 people. She did it this one in 1960s and 70s. Her name is Donna Meadows. She is a professor of Dartmouth College. I'll tell you about her a little bit more. But she did a study on the if that they took the study and then they make it 100 people. If there were the whole planet is 100 people, what would be? So I'm going to show you a video so that you see. Please watch this video. Just a minute. This is let me bring this video together. Why? Oh, sorry.
The 100 People Foundation is asking 500 schools from 100 countries to nominate 10,000 people to help us find the 100 people that best represent our world population. We've created a lesson plan that explains how a student can nominate someone they admire from their local community and fill out a community profile that helps us understand where they come from.
This is my schoolhouse. Masaya ako na interview ako, na camera ako. Masaya ako na nakilala ako nila, ma'am, natulungan nila ako. Masaya ako na, masaya ako. Lalo na sila, masaya ako. Kasi as in, hindi ko sa depalayan na ganito, interview na ako, may camera ako. Kasi sa amin, wala.
We are asking the children of the world to introduce us to the people of the world.
I think this project will really open the eyes of a lot of people that we're not alone in this world. That it'll be good to see how everyone else lives in the other side of the world.
Irsiba kala dori dum din imirga bora kulmete mefo imdu doro din kaban bora imfai bora kulu imete mefo imfai di yanja asibo.
That yeah, 1 second. I'm going to bring that. I'm trying to bring that. What happened is this? Yeah. Okay. So that is the video about the 100 people. If the world was just 100 people who live, what the distribution looks like, So you get the good idea that you can connect with the people more. So Donna Meadows was born in 90. Donna Meadows. She is let me make it a little bit bigger. Donna Meadows was born in 1941. She was born in Chicago, suburbs of Chicago. She did a PhD in biophysics from Harvard. and a MacArthur Fellow. MacArthur Fellowship is a genius. People get that fellowship. She's a recipient of a MacArthur Fellowship. She did a computer. She did a computer modeling MIT at the MIT. She was a magnetic storage. She was one of the inventors of the magnetic storage. She involved in the, and then she invented a process called. She was the mother of a system dynamics. I tell you what the system dynamics is. So she went through her husband herself. She got married, and she went through Afghanistan, India, Afghanistan, Pakistan, Iran, Turkey, Sri Lanka for the whole year in an ambassador car, and ran through the entire whole year she spent across the countries to understand the world of the 1970s. Beginning of the 1970s, she did travel around to get the good understanding of this professor from Dartmouth. At that time, she was not a professor. She has a PhD from MIT. Then after that, she did a professor she became a professor in Dartmouth College, in the very prestigious college, right, in the New Hampshire. That her name is Danella Meadows. A lot of people don't know. That's what I want to bring. She wrote two very important books, Thinking in Systems and then The Limit to Growth. The governments, policymakers, academicians, they bought this book in a millions, 500,000. Thinking in Systems was sold 500,000. And then Limits to Growth is a 28 different languages were translated into the 28 different languages, Donna Meadows' books in the 1970s and 80s. So what is the book, Thinking in Systems? She was saying all the systems are complicated in the sense that you have to think like you don't say complicated. That's just a vague word. What she did was she fractalized that wording, and these are the parts that consist of that whole complex system. Interconnectedness. What is interconnectedness? If you translate to healthcare, I did translate to healthcare. For example, patients, doctors, financing, insurance companies, all the healthcare plans, all of them are interconnected. So you cannot take one and decide what it is. So interconnectedness, you have to define clearly about that. That's what she said. The second part, she talks about stocks and flows. It is for example, here the admissions rate coming in, coming out. How does it work? Engineering. She's an engineering system. She's putting. That's what the system dynamics is. Kind of engineering. Feedback loops. This is one of the most important one, because a lot of EMR systems are rigid. It won't take anything patients tell you or nurses tell you. They can't change anything. They're dumping on the. That's one of the resistance from the. We can ask Fatima about it. So they're dumping all these EMR systems on the nurses and everybody to do it. They're not telling how do what they need, what they like. It is not a feedback loop system. Is not there. That's one of the problem with the EMRs. So leverage points. She says that certain things you do, you don't need it's not only money, but certain things you do, the outcomes are much better. Preventive care, for example, it will produce better results than healthcare education. Health education, preventive care can produce better outcomes than just treating diseases. So leverage points. She identified these points clearly, and then holistic approach. They need for example, opioid crisis. You need to work with the not only communities. You need a social determinants, for example, and economic systems, where they come from, what they do. That's why I was attending today that kind of a seminar today. So gun violence, all of them are involved in this. The law enforcement, all of them are involved in the holistic approach. You got to do all of them together. So she was saying all these points are well-defined systemic procedures. So you can implement this one. Then only you see some kind of a side of it. So the leverage points, for example, she's talking about high leverage points are disease to prevention. That's what he's saying. Mid leverage points are transparency, price transparency, for example, would be very effective. Low leverage points are building resource buffers. What are the important resources? If disease prevention is really in the top, that produces better outcomes. Dominant transparency. Transparency is the price transparency he's talking about. That is important, but the better outcome is always you put all the resources in the disease prevention itself. That's what the for the system dynamics of the healthcare system. She wrote the book on that in the system dynamics engineering point of view. But overshoot the collapse and all those things. Donna Meadows did the healthcare system. So let me give you some idea about 1,000 doctors in the United States. Cuba is of 8.4 doctors out of 1,000 doctors wise. Cuba is 8.4. That's the highest number. Monaco has a 7.5. USA is a 2.6. India is a 0.9 for a 1,000 population. The numbers. Niger is the lowest, 0.2. Nurses wise, Finland has 19, and the USA is 17.5 in the nurses wise. India has a 1.6, and South Africa is a 0.9. You know, so maternal mortality rate, for example, Finland is the lowest. United States is 32.9. India is 100, and South Sudan is 1,200. That is out of 100,000. India is United States has one of the highest maternal mortality rates. Infant mortality rate in the Morocco is the lowest actually. United States is one of the highest in the infant mortality rate, 560. India is a very high, 2,769. Sierra Leone is 8,000 people die. That's a lot of people. Mammograms, for example, I give you mammogram tickets. Let me give you mammograms just again. Mammograms in Italy is 80 out of 1 million. USA is 79. India has a 2. So radiation therapy centers, USA is 12.4. India is a 0.4. Africa is 0.28. 65 cellular internet. 65 would be cell phone users. This is one of the areas where we are successful about cellular internet. We are covered almost 65% of the earth, almost covered. Quality measures in the United States are inpatient, prevention, patient safety, and pediatric care. So quality measures are, if you don't mind, support cost and patient and cost of resources. That's what I do. So then those are the countries with the oldest population: Japan, Italy, Germany, and China. So the countries with the youngest population is Africa. African continent has the youngest population. That's the statistics are saying. So the mother of all these things, system dynamics is doing, is the Donna Meadows was the System Dynamics Society. She is actually instrumental in forming that kind of thing. So health policy special interest group, they write the engineering aspect of it. That's what they do. So anyway, inspiring. Donna Meadows died in 2001 with bacterial meningitis. Inspiring environmentalist, scholar, writer, and a teacher. The Donna Meadows project is a DonnaMeadows.org. That is okay. Anyway, I have to. This is the system that I presented. Thank you for watching. Let me bring here for a couple of minutes, and we'll go after that. And I need to. That I'm a little bit of a bind here. Very unfortunate because I'm a traveling and anyway, that's okay. But Fatima, tell us a little bit about your Indian organization. You started it, that for your founding organization.
Yeah, thank you. I really appreciate it. And that was really great about Donna Meadows. I'm gonna check that out. I really like your analogy. But real quick, with our time coming up, as a founder of Bay Area Indian Nurses Association and the chapter president, which is really part of umbrella, this chapter is from National Association of Indian Nurses of America, and there is a national organization, and we are a chapter. And I'm really excited to create this platform along with my board members who are amazing nurse leaders and nurse clinicians who agreed to join me on this bandwagon to really support the Bay Area nurses. And I'm grateful for nurses who have come across and the support from my organization to help move this forward. And if you are watching this, please check us out. We have our LinkedIn page called Bay Area Indian Nurses Association. And what we are really hoping to do is be really actively engage within the Indian community and for the minorities, for succession planning, but also serving our community, as Dr. Um, Ramana earlier talked about, was really, preventive medicine, right? But we need to be in our community to talk about how are we going to support and really tackle issues with mental health. Suicide rates are really high in Indian community. LGBTQI plus issues, as we will be serving that population. Like if you are an Indian person, the transgender community or Hijra, as you say in India, but really looking at those kind of community, because for me, I'm queer. And for me, that is an important issue for we need to tackle, and really, as an Indian community, come together to see how are we going to serve our own people, and how do we educate and how do we serve the community beyond just our Indian community, the country that we live in. So there are a lot of other issues where I want to talk about sexual assault, mental health related issues, domestic abuse. In part of the preventive care that we are talking about. So I think there's an opportunity for Bay Area Indian nurses to really partner with our Indian community and our physician partners and allied health team members to provide that support, but also succession planning of nurse leaders and nurses within the community and advanced practice providers. So
Oh, thank you so much. It's so honored to have you. When I come back to Silicon Valley, I will do a good interview with you. So sorry about that. I've been traveling and I'm in the middle of a mess here. So, but
no
anyway,
worries.
thank you
Thank you
so
so
much.
much for your time.
It's truly honored to have you, Fatima. It
Same
is a
here.
blessing. Thank you so much. You are very
Thank you.
informative, eloquent speaker. You are one of the best, the model for mentor for all of the Indian nurses, not only Indian nurses, all Indian population. Thank you so much. Thank you.
Thank
Honored
you.
to have you.
Thank you.
Good night. But good night.
Good night.
Telling their stories through our patented designs that can be worn on scrubs, t-shirts, printed on conference bags, and endless other promotional materials. Daily Wear for Medicine is the first ever of its kind to create curiosity in medicine through visual art. We at MedBricks are celebrating unsung heroes of the past who made enormous contributions to the field of medicine through our unique campaign called Daily Wear for Medicine. You can wear it, carry it, and give it